Mary Hubert is a practicing palliative care physician, and she's been doing this since 2011. She opened the first palliative care clinic in Louisville. She now practices both outpatient and inpatient for the Norton Cancer Institute and at the Norton Hospital downtown. The majority of the patients that she sees do have cancer, and she manages their symptoms related to the malignancy and helps them with their goals of care, promotes best quality of life as patients navigate their cancer treatments. Dr. Huber received a BA from Tufts and an MD from the University of Louisville School of Medicine. She completed an internship and residency in internal medicine at the University of Louisville and was chief resident there. She completed hospice and palliative care medicine fellowship at the University of Louisville also, and she's board certified in internal medicine and HPM. And she's a member of the American Association of Hospice and Palliative Medicine. With updates in palliative care, here is Dr. Mary Hubert. Mary.
Thank you. It is really a pleasure to be here speaking with you all today. I appreciate the opportunity. Okay, let's see if I can work this. Okay, no disclosures. So, like Dr. Ham said, I'm practicing outpatient palliative care, and our clinics are embedded within the Norton Cancer Institute settings. The majority of the patients that we see do have cancer, and the majority of the referrals to clinic are for management of symptoms either related to their malignancy or the side effects of treatment. So the studies that I chose to talk about today have to do with how we manage those symptoms. The first one is a phase 3 randomized placebo-controlled trial on repurposing olanzapine for prevention of radiation-induced nausea and vomiting. And this was presented at this year's ASCO annual meeting in June. Patients were 18 years and older, had not received previous radiation. They were planning on receiving radiation to the abdomen or pelvis, and they were randomly assigned to receive either ondansetron, 4 milligrams twice a day with placebo, or ondansetron, 4 milligrams twice a day, along with olanzapine, 5 milligrams daily. These are the two groups, and they are roughly similar. About half of them had rectal cancer, 30% prostate cancer, nearly 10% endometrial cancer. The vast majority were getting radiation to the pelvis, over 90%. The dose here, let's see. Do we have a laser? There we go. Back up one more. So the dose here, I imagine this is centigrade. I'm sorry. That would be more like 2 gray, and that's a day. And the duration in both arms was very similar, 23 days. So all in all, 2 very similar groups. And what they found, looking at nausea, the reduction in nausea and vomiting is striking. They found that nausea occurred in about 83.6% of patients getting ondansetron only, compared to a much lower 14.2% in the group getting olanzapine as well. Grade 2 nausea, so moderate in severity and affecting daily activities, occurred in 67% of the group getting ondansetron, 4 milligrams twice a day, compared to a much lower 7% in the group also getting olanzapine, 5 milligrams daily. So big reductions in numbers, and this was across a variety of cancer types. When they looked at vomiting, this occurred in about a quarter of patients getting ondansetron only, compared to a much lower 4.1%, and the patients also getting olanzapine. In grade 2 or higher vomiting occurred in about 7.8% of those on ondansetron with placebo, compared to 1.3% getting the olanzapine in addition to ondansetron. So really striking results with the addition of olanzapine 5 milligrams a day to ondansetron 4 milligrams twice daily in these patients getting largely pelvic radiation. Then they also looked at other symptoms, and they found that not only did the olanzapine improve nausea and vomiting, but it also helped reduce mean anxiety scores in the folks getting olanzapine. And there was a similar trend observed for mean depression scores in those patients. They also found that they had better quality of life when it came to the functional scale, and also improvements in sleep and in appetite. And I would say that in clinical practice, this is what I see in the patients in clinic that also are getting olanzapine. They do seem to have better sleep, better appetite, their mood improves, and less nausea and vomiting. So the second study I want to look at is one involving buprenorphine naloxone for management of chronic cancer pain in a palliative care clinic. This appeared in the Journal of Palliative, actually the Pain and Symptom Management Journal, which is the Journal of the American Academy of Hospice and Palliative Medicine. This was a retrospective descriptive study in a tertiary cancer center-based palliative care clinic in Edmonton, Alberta. They looked at 47 different patients who did have advanced cancer and were getting cancer treatment at that time. And what they did is they rotated them from full agonist opioids, so things like morphine, oxycodone, to buprenorphine naloxone. The average age was about 56 years old. These patients had been on full agonist opioids for an average of 18 months, so about a year and a half. And the mean oral morphine equivalent daily dose, so we talk about the MEDD, for these patients was 122 milligrams of morphine equivalent before rotation. So this is a significant amount of pain medication that these patients were on. And after rotation to buprenorphine, they were, on average, able to achieve stable pain control at about 4.6 milligrams of sublingual buprenorphine. So the mean conversion dose ratio that they found was oral MEDD, or the morphine equivalent daily dose, to sublingual buprenorphine was 39. So that basically means that it took about 1 milligram of buprenorphine to equal 40 milligrams of morphine equivalent. So it is quite strong. These patients remained on buprenorphine naloxone for an average of over 6 months. They did see a clinical improvement in their pain score when they used the Edmonton Symptom Assessment Scale tool, which is what we use in clinic. And we basically ask our patients at each visit to give us a score for 9 different symptoms using a 0 to 10 scale. And so we saw that number drop in this study, and clinically significant is usually coming down by 2 points on that scale. And these patients were able to achieve clinical improvement. And so I mentioned this study because I want people to realize that buprenorphine with naloxone, not only does it help patients that have opioid use disorder, but it also can be used as an effective pain medication for patients that have even cancer pain that's significant. So I would encourage, when providers have patients that are on Suboxone or buprenorphine naloxone for opioid use disorder, when they're diagnosed with cancer and they develop cancer pain, to talk to the provider of the buprenorphine to see if it can be dosed in a way that will help with their cancer pain so that they can stay on this successful medication for their addiction. But in this study, why did they rotate to buprenorphine in the first place? Why did they take these patients off of their full agonist opioids? So the reason they were interested in doing that is because thankfully people with cancer are living longer. And unfortunately, this means that they're living longer with chronic cancer-related pain and also treatment pain affecting their quality of life. And the way we manage this is still usually with opioids. And we know that when patients are on opioids long-term, which is longer than 90 days consecutively, that there is an increased risk for adverse effects, and that can include the development of opioid use disorder and overdose, hypogonadism and endocrinopathies, and also immunosuppression. And these are things that we don't worry with buprenorphine use. Patients don't develop endocrinopathies. There's no risk of immunosuppression, a much lower risk of overdose or respiratory depression, and it's actually how we manage opioid use disorder. So a good choice when we have to keep somebody on opioid therapy long-term. So the way buprenorphine does this is it's a partial mu opioid receptor agonist, so it helps with pain. It's also a kappa and delta opioid receptor antagonist. So it helps reduce the development of hyperalgesia and tolerance to opioids. The great thing is it also has a respiratory depression plateaus, so a ceiling on respiratory depression. So as we increase the dose of buprenorphine, the risk of respiratory depression doesn't continue to increase, it plateaus. So buprenorphine can be a really good choice for patients that are displaying aberrant drug-related behavior or have a history of opioid use disorder, or for our patients that are being treated for anxiety with benzodiazepines, because we know that increases the risk of respiratory depression and overdose. So buprenorphine can be a really good choice for these folks. There's also evidence that it helps with mood and sleep, and a lot of our patients have those concerns. There's been a large systematic review looking at greater than 12,000 people with chronic pain, and they found that buprenorphine was as effective as full agonist opioids in managing chronic back pain, osteoarthritis, neuropathic pain, and cancer-related pain. And I do see this in practice. So the really important thing to know is that there are basically two groups of buprenorphine products. There is the really low dose group, dosed in micrograms. These are things like the buprenorphine patch that you wear on your arm. Also, there is a buccal film that is used twice daily. These are FDA approved in the United States for management of chronic pain. Anybody with a DEA can prescribe these low-dose formulations of buprenorphine. They're a good choice for elderly patients or people that are frail or people that can't tolerate even low doses of opioids. They can be a first-line agent as well, and the buprenorphine patch, starting at 5 micrograms, a very small dose, can be started in someone who's opioid naive. And does have all of those benefits of helping with nerve pain, sometimes mood, safe in renal failure, also in hepatic insufficiency, so lots of reasons to choose it. Then the second group of buprenorphine products is often combined with naloxone, like in the study I presented, often in pill or sublingual film, and this is only FDA approved for opioid use disorder. Some states, they will use it off-label for pain, but in Kentucky, this is illegal. We can't do this here. There have been some proposals made to change this regulation so that oncologists, palliative care specialists, pain specialists can use these formulations in patients at the end of life or struggling with significant cancer pain. But at the moment, using the high dose in milligram formulations of buprenorphine with naloxone, we can only do that for opioid use disorder. But what we can do, like I said, is for patients that have opioid use disorder and also have cancer pain, we can adjust the way it's dosed. So we're still using it for opioid use disorder, but we can also manage cancer pain that way and keep people on treatment for their addiction. Okay. And lastly, there was a lot of discussion this year at ASCO's annual assembly about cannabis and cannabinoids. So I thought it would be good to just briefly review the ASCO guidelines that came out last year. An expert panel reviewed 13 systematic reviews for randomized controlled trials in a cohort study, and they put out a group of recommendations. The first group has to do with clinical communication and education, and they encourage clinicians to offer adult cancer patients unbiased and evidence-based educational resources to foster open communication and guide decision-making for patients about use of these products. And then we're encouraged to also inquire of our patients if they're using these products or intend to, so we can help with decision-making. In terms of cancer treatment, these ASCO guidelines encourage clinicians to recommend against adding cannabis and or cannabinoids to augment cancer treatment, unless in the context of a clinical trial. And ASCO also encourages clinicians to recommend against the use of cannabis and cannabinoids in place of cancer-directed treatment, and that's a strong recommendation from ASCO. In terms of symptoms and side effects of treatment, recommendation 3.1 says that adults who are receiving moderately or highly immunogenic cancer treatment and are getting guideline concordant prophylaxis for nausea and vomiting yet are still having refractory symptoms, we can augment their antiemetics with things like dronabinol, nabilone, and quality-controlled oral 1-to-1 THC and CBD extract. Outside of a clinical trial, we're encouraged not to recommend adults take more than 300 milligrams of oral CBD due to lack of proven efficacy in managing symptoms, and also due to the fact it can cause reversible liver enzyme elevation. And then finally, they encourage us not outside of a clinical trial to recommend use of these products in managing other symptoms due to lack of proven efficacy. And then in Kentucky, I think we all know that at the beginning of the year, medicinal cannabis use became legal in Kentucky. And to become a medical cannabis practitioner, you do your 6 CME hours of KBML approved credit, and then you apply. But really, regardless of whether people want to do that, we all should be aware of drug interactions with cannabis and cannabinoids, because there were ASCO abstracts that reported doubling of side effects when cannabis and cannabinoids were used with antipsychotics, opioids, benzodiazepines, antidepressants, antihistamines, alcohol, carbomelatonin, and saccharin wort. So a lot of things that our patients take. Also, an ASCO abstract encouraged that it be contraindicated with warfarin, amiodarone, levothyroxine, glivexam, lamotrigine, and valproate. So a lot of potential drug interactions. And again, this is why we should be asking folks if they're using these products so we can help educate them about potential drug interactions. And that's it. Thank you. Any questions?
So this may be a boiling the ocean question in some ways, because we've heard today from Dr. Agarwal with sexual dysfunction, we've heard about aspirin and physical therapy with Dr.
Yeah.
Wilson, we've heard from Kaylee and Kayla around just toxicity, so I'm lumping these all together. I mean, in your world, which is a consultative model, what do you see would be the ideal thing? And this is kind of outside of scope and talk, but I'm just sitting here thinking that patients have many different things they're suffering with, and that
Yeah.
it seems to me that if we make the only mechanism to overcome these, like buprenorphine, who's going to do that microgram dosing other than maybe you?
Mm-hmm.
How do we set this up so that people get exposure to these things more globally and adopt them so they don't have to consult?
Right.
Or they know enough to even ask?
Right. That's a great question, because when I got my X waiver, I sat in class for 8 hours with Kelly Cooper, and she did a great job, and I learned all about it. Nowadays, it doesn't take that. It doesn't take that amount of sitting in class. There's a movement to get more people involved in using buprenorphine to manage opioid use disorder, because it's something that is much lower risk than many of the things that we do every day. So there's no reason we shouldn't be doing these things. It does take some education, and then the low dose buprenorphine, everybody can do that, minimal risk. And at those doses for that buprenorphine patch, there is some concern about QTC prolongation, but that's at higher doses that they use in Europe. But what we're doing, we don't even have to monitor the EKG, and less risk of respiratory depression. So I think we need more education. We need more education because we can do primary palliative care. That can be done at a lot of different levels. Primary palliative care, that can be done by primary providers and PCPs, and we really need to do a better job educating folks. They can do this. It doesn't have to be something that comes to palliative care necessarily. Mm-hmm.
Thinking that we've done so much better than 20 years ago, I promise, but what is that next thing that's going to get us there?
Mm-hmm. And I think also removing the stigma about asking about these things is important, and normalizing these medications too, and making them more available to patients. Yeah, thanks.
Thank you, Dr. Hubert. Holly Stallings has been the Director of Quality and Accreditation for Norton Cancer Institute since 2008. She earned her nursing degree at Murray State University and her master's in public health at the University of South Florida. She has certifications in both quality and public health. Most of Holly's nursing experience has been in the oncology space and in hospice. She has over 30 years of quality and accreditation experience. Holly participated in the ASCO Quality Measure Working Groups and was a member and is a past chair of the ASCO COPE Steering Committee. And I might mention, I think she was the first non-physician to chair an ASCO committee. She spent the last 10 years as an ASCO performance improvement coach, which is in the quality training program that they have. And she's trained oncology teams across the country at a number of universities as well. Presenting redesigning cancer care, payment reform, equity, and quality outcomes. Please welcome Holly Stallings.
Good afternoon. I know there's 40 minutes left, so I'll try to keep this sweet and short. Plus, Joe is watching me. So I chose this topic because it's a big buzz in the quality circles around payment reform and health equity and quality outcomes, but particularly payment reform and health equity. So, and these are my objectives. So I'm framing this talk around the patient. And you could say our patient is our North Star. When Leah or Renee, Becky, Dr. Agarwal goes to work every day, their patients are their priority. And they're my priority too. When I agreed to do this presentation, I was thinking healthcare reform, payment reform. It's not a very exciting subject. So I'm apologizing ahead of time. It's not as exciting as, Dr. Agarwal's speech or any of that. So that said, healthcare reform is important, and payment reform will impact patients and our North Star and our families. It can impact positively or negatively. Healthcare reforms also impact the way we care for our patients and how our clinic operates. Redesigning cancer care is critical. Our current care delivery system is not meeting our patients' needs. We are seeing efforts, but it's a challenge to make things both affordable, high quality, and equitable. So before we get started, I want to make sure we're on the same page. I want to talk about payment and healthcare reform. I'm simply referring to legislation and laws designed to transform how we pay for and how we deliver healthcare. Okay, it could be one or more goals. Reduce healthcare costs, pay for value, not volume, improve quality of care, better outcomes like survival, or improve care delivery, which makes care more efficient, coordinated, accessible, and patient-centered. So our country spends a tremendous amount of money on healthcare, more money than similar nations. Despite all our spending, our cancer-specific outcomes are not quite what we would expect. Patient outcomes like mortality are still vary among race, gender, rural, LGBTQ populations. So how much money are we spending? This graph shows U.S. healthcare expenditures over the last 50 years as compared to like countries. And we've always been more expensive than like countries, but the gaps widen. As you can see, we spent $4.9 trillion in 2022, 17% of our GDP. I highlighted two countries. You see Australia on the right and the US on the left. They both have very similar quality outcomes, but you could see the United States pays over twice as much as Australia. Okay, so we love our pharmaceutical companies. Just want to say that. They give us a lot of help with our patients, help pay for meds, fabulous medications, but again, we're still paying more for pharmaceuticals. We've heard how an illness, either catastrophic or chronic, can hurt a patient financially. The rising cost of healthcare has resulted in 4 out of 10 people having medical debt. 2 years ago, the total medical debt was $200 billion. You could see from what I highlighted that 87% owe $5,000 or more. Most of them owe more than $10,000. So we can acknowledge that we spend a lot on healthcare. Let's take a look at the current state of quality outcomes as compared to other countries and different populations. So this graph shows mortality rates and cancer care expenditures for the US and similar nations. So I highlighted Spain in yellow and the US in red. Okay, the horizontal axis is cost of cancer care, the right being 0 to 600. You can see that Spain spends $132 per capita. The US spends $584, so over 4 times as much. The vertical axis is mortality, lower mortality being on the lower part of the scale. You could see that Spain and the US have very similar rates. Spain's is 62 and the US is 69. Okay, so similar. US is doing much better than a lot of countries over there on the top there, Netherlands, Germany, New Zealand, so our mortality rates are better. However, the point is that you don't have to spend a lot of money to have good outcomes. So let's look at outcomes by race. So this example focuses on breast cancer deaths. The good news is we're seeing a decreasing death rate, but not by everybody. So you could see on the Asian populations, it's rising. Also, you see that African American deaths are much higher. They're at a higher rate, even though white women have a much higher breast cancer incidence. So if we look at screenings, you could see in the colorectal screening that we have disparities between white adults and other races. Okay. A few more populations. Rural residents are dying from preventable cancers like lung and colorectal. Some of the disparities in the rural population are related to lower screening rates, limited access to health care, providers and travel is an issue, as well as poverty and lack of insurance. LGBTQ patients have a higher incidence and later stage of diagnosis. They're more likely to be underinsured or uninsured, and they're more likely to experience poverty and food insecurity. There's a high incidence of depression. Transgender and non-conforming patients are more likely not to be offered breast, cervical, and colorectal screening. So disparities persist. Every cancer patient should have the same chance to live a healthy life as possible. We have guidance and support from our professional organizations. Health equity is a guiding principle of ASCO, National Cancer Institute, ONS, and support organizations like American Cancer Society. It's a huge priority with Norton as well. Healthcare providers, we play a key role in identifying and addressing their barriers to care and social needs to promote equity. So many of you have heard of social determinants of health, or SDOH. I know a lot of you have heard it from me. Social determinants of health are non-medical factors affecting healthcare. Many healthcare organizations are assessing our patients for SDOH, such as food and housing insecurity, which can be barriers to care. An SDOH assessment can include some or all of the items listed on there. If we improve social determinants, it can improve outcomes. For example, if a cancer patient is in poverty and has limited access to food, if we provide food assistance, they have better nutritional status and they can better tolerate their treatment. We've all dealt with challenges of a homeless patient. We arrange support services in hopes that a homeless patient can adhere to their treatment plan and improve survival and quality of care. Kudos to a lot of the social workers and navigators and everybody that connect our staff with with resources for SDOH. The pharmacy teams and financial counselors help patients with medication, and all these efforts are helpful. However, healthcare and organizations can only do so much. In order to achieve and affect a larger population, we need a broader measure to improve quality and access to healthcare. And this can be done by legislation. So these are some examples of past legislation that have improved access to healthcare. In 1996, we had HIPAA. We know that HIPAA helped with privacy, but it also removed pre-existing conditions. This was a huge win for cancer patients. In 2000, legislations allowed states to fund breast and cervical cancer prevention and treatment. In 2002, we passed laws to expand community health centers. In 2010, the Affordable Care Act expanded health insurance and Medicaid coverage, allowed for preventative services, and also quality reporting. In 2020, COVID pandemic legislation expanded the use of telehealth, and we still today, it helps with access to rural, end-of-life, and disabled patients. Excuse me. So let's take a look at current reforms and how it impacts our cancer patients. So I want to share a quote because there are reforms that have had a positive impact and some that have had a negative impact. And most of us feel like we don't have any control over it. I believe knowledge is power. The more we understand how healthcare reforms can influence cancer care and our patients' lives, the better prepared we are for any challenges. We want to be realistic, a bit optimistic, and be prepared to meet our patients' needs. So hope for the best, prepare for the worst, and unsurprised by anything in between. So one of the most transformative laws was MACRA in 2015. So MACRA established the Quality Payment Program. The goal is to pay for value, not volume. Healthcare providers are evaluated and rewarded for cost, quality measures, IT, and performance improvement activities. At the end of the year, depending on the score, providers receive either a positive bonus payment or a negative adjustment. And around 2003, CMS launched OP35, which is near and dear to my heart. OP35 measures the number of chemotherapy patients that have ED or admissions for what they call avoidable diagnoses. They use a year's worth of claims to determine the rate of ED and admissions, and then they post your OP35 score against other institutions publicly. Next, we have the budget reconciliation law. Okay, so how will it impact our patients? This is strictly a payment reform. It will reduce Medicaid funding and allow the ACA subsidies to expire later this year, unless something happens. The enrollment for the ACA marketplace opens in 2 weeks. Insurance companies have already posted their payment increases. So you could see Kentucky's payment increases are between 15 and 37%. And actually, Indiana is even higher. As a result of changes in insurance premiums, patients and families may opt for a cheaper policy with less coverage and more out-of-pocket costs, or they may choose not to have any insurance at all if they can't afford it. Changes in Medicaid funding and requirements will result in a lot fewer patients being under Medicaid. So the results are uninsured and underinsured. This graph shows disparities in insurance coverage back in 2002. The dark blue represents private insurance. Medicaid is in light blue, and uninsured is noted in green. So you could see the difference among the groups already, and this gap's going to likely widen. So how does this law affect providers? So the budget reconciliation law is going to have a huge impact. So hospitals currently receive between 15 and 25% of revenue from Medicare and between 14 and 19% from Medicaid. And rural hospitals probably receive more. Changes in reduced revenue and more patients are going to be uninsured, meaning a larger percentage of uncompensated care. There may be limits on services, and rural hospitals and clinics are at risk of being shuttered. So I want to call attention to proposed legislation. So this is something proposed, but it started back a couple years and it's been resurrected. It's called the Site Act, and it's about site neutrality. Currently, hospital outpatient departments receive an additional fee from Medicare to help pay for free resources we get to patients, like dietitians, social workers, financial counseling, navigators, and so forth. So unlike private clinics, hospitals have more overhead costs and costs related to compliance like DNV and Joint Commission. Hospitals tend to have more medically underserved patients and complex patients. The SITE Act proposes to eliminate the fee totally. So a service will be paid the same regardless of site of care. Revenue will be reduced, and if the fee is eliminated, hospital services may be reduced. So some closing thoughts. Redesigning healthcare is a delicate balance. We have cost of care on one side and quality and disparities on the other. We saw how some key legislation over the last 30 years improved outcomes and disparities through access, but it didn't affect cost of care. We all recognize that costs of care are out of control. Our patients are going into debt. Value-based care is a good concept. Reward quality, outcomes, and health equity while controlling costs. Unfortunately, it's a long road. There's a lot of trial and error, and we're not there yet. Recent legislation focuses on cost of care, but it doesn't reduce the patient's out-of-pocket costs. In addition, it will reduce access to care. Sorry. Thank you. Okay. Recent legislation focuses on cost of care, but it doesn't reduce the patient's cost of care. So no one walks this tightrope more than you all. You go to work and focus on your needs of your patient, your North Star, as best you can. In the meantime, knowledge is power. Understanding the current state of healthcare reform, understanding how our patients will be vulnerable, and understanding our patients' barriers will help you navigate with confidence and purpose. Thank you.
Do we have any questions? No. Well, thank you very much, Holly. Oh, is there a question? Oh, I'm sorry, I missed that.
You showed a slide about the high cost of pharmaceuticals, and I know the Trump administration has been working to try to maybe negotiate rates. Can you comment a little bit on that piece?
Yes, and actually, we did negotiate some rates already from the previous administration, and I actually skipped that slide, but trying to move along. But actually, we did reduce them, but in compared to other countries, we're still a lot higher, but it did help, and it helped with the out-of-pocket cost. So hopefully we'll have some more. So that would be great.
Again, thank you very much, Holly. Dr. Elizabeth Archer-Nanda has been in oncology for 24 years, initially as a nurse, 20 years as a psychiatric clinical nurse specialist. She is the founding provider and program leader for the Norton Cancer Institute Behavioral Oncology Program. Elizabeth has served on many committees both within and outside of Norton Healthcare. Many of you may not know, but she was just last year the president of the American Psychosocial Oncology Society and is this year serving as the immediate past president. Dr. Archer Nanda is interested in the development of sustainable models of psychiatric care with expertise and tenure in psycho-oncology. She's an advocate for a positive work culture, inclusivity, and the just work environment. She's also my riding partner in the Bike to Beat Cancer every year. Elizabeth?
What I was grateful Dr. Ham left out, but I will tell on myself, is that he trains a lot harder, he wears clip-in pedals, and so he actually effectively pulls me to the end of the Bike to Beat Cancer every year. So it's a pleasure to ride with him. We're going to talk a little bit about the human side of cancer. I don't have any disclosures. I will set some ground rules and just ask that you can be curious and present. I promise we will leave on time. I know that I stand between you and your afternoons with your friends and your family. If you need something during the talk, ask for it. And it goes without saying that we won't cover all there is to know about psychosocial oncology in 17 minutes or less. And so we won't get to everything, but if I can answer something for you, just let me know. So we're going to talk a little bit about psychosocial oncology for oncology patients and when to refer to mental health. And then we're going to talk a little bit about how we integrate well-being. A lot of the job of the psychosocial oncology provider and clinician, an oncology provider and palliative care provider and sexual health provider is to sit with patients in their own discomfort and help them to regulate their own emotion. And so we become co-regulators all day, and that takes a tremendous amount of energy, effort, and patience, and it takes just a lot of time. So is anyone familiar with the Zen art of kintsugi? Okay, so the Zen art of kintsugi, everything created will break. And we can pick up the pieces and put them back together. There's a strength and dignity and beauty in this process. It's not imperfection, it's life. We're not holding the fact it was once broken. We're not calling to part the repairs, but we are looking at the beauty. They use this beautiful gold to glue things back together when they've broken, and there's beauty in that. We can find strength in the process. There's acts of love and kindness and generosity and support that can come with a cancer diagnosis. And there's a lot of pain and challenge and struggle as well. And this is what we do with patients every day. This is what we do with one another each day. And so there is beauty in this brokenness and the repair. I'll talk a little bit about two patients throughout this presentation. I think it's important for us to acknowledge that the patient on the right, who I call Cher, and some of the members of the team here have taken care of Cher with me in the past. Cher looked like a lady who probably needs psychiatric care. She presented, they're smiling, they're nodding their heads. They remember Cher. Sometimes she streaked down hospital corridors naked and yelled and tried to jump off of things. And Cher looked like she needed us. And actually the same team took care of Big D on the other side, who did not look like he needed us. But he actually presented in a psychotic episode induced by high-dose steroids. And so it is important for us to note, you can look like a patient who might need psychiatric intervention and also look as calm as Big D did when he came to us. And it is difficult sometimes to predict who may need a psychiatric or psychosocial intervention throughout care. Cancer is a life-threatening disease, so there can be feelings of sadness, worry. Patients can feel overwhelmed to the point of panic. They have decreased capability cope with side effects, including pain, fatigue, poor concentration. We talked a lot about memory changes when we talked about some of the advancements in radiation treatments. Patients can feel despair and hopelessness and can feel really, really overwhelmed. And we have to support patients to move through this process of coping with something that seems to be unacceptable. It's not a sign of weakness to experience distress, and it can range on a paradigm of mild distress to severe distress. I think it's important to be able to delineate between the two and to understand what patient support systems exist, as well as how to get them into appropriate resources when they are having a harder time coping. Mark Brackett is the leading psychologist at the Center for Emotional Intelligence at Yale, and this is his work. Mark is a researcher. He helps school systems to understand how to help children emotionally regulate. I think all of Mark's work is applicable to cancer care. So if you look at this map, he calls this the mood meter. On the top, I don't know why I'm getting a little bit of a kickback, but on the far side where it's yellow and green, those are more pleasant emotions. The top half, those are higher in energy pleasant emotions. The bottom half are lower in energy pleasant emotions. And on this side, you have lower pleasantness emotions. The top half is high energy, low pleasantness. The bottom half is low energy, low pleasantness. He's really clear to say that there aren't good or bad emotions. Emotions just exist, and they are. Think about where you're sitting on this mood map right now. Some of you might be sitting in that, I don't know, you might be a little bit in the red corner, okay, is this gonna end? I wanna get out of here. I'm feeling slightly jittery, or you might just be feeling kind of tired. We've been sitting for a long time. I realized that my cap for concentration was somewhere around the 3-hour point, and I needed to stand up, move around, get something to drink. In our culture, we feel like we perceive that it's normative only to be in that top yellow box. As a mental health clinician, I'll say that the top right corner, or top left corner rather, ecstatic, that's not normal either. We should not be ecstatic at all times, right? That also is indicative of some mental unwellness. So what we've worked to do in our program and in my clinic, I definitely work with patients to help them to understand we want you to move around this box all over the emotional map every day. I take care of a gentleman who had neck cancer, and he had to have a total laryngectomy this past year. It was a really difficult decision for he and his significant other for him to go through that procedure. And he's a retired bus mechanic, and he came back in with this grid. He was able to speak with his voice box again, and he said, I figured it out. As long as I stay out of the corners, I'm gonna be okay. And that really hit for me. I was like, he heard me, he's okay being all over this emotional map now, not just feeling happy, but knowing that the corners aren't where you wanna sit. This is the mental load of a cancer patient. Holly just talked a little bit about some of the financial toxicity of cancer. Dr. Agarwal talked earlier about the sexual burden of cancer. People are experiencing pain, grief, difficulty coping, feeling as if they're a burden on their support systems, existential concerns, mental health concerns, and this uneasiness with not knowing who to ask certain things to, who's the specialist that I need to go to with this question. And it can be really, really overwhelming. When I look at this, I think just how difficult it must be for a patient to know who they even need to ask this question to, and where they reach out for the support. So some of what we can do as medical providers is to work to build trust with patients. I think anytime we can minimize power differentials, making sure patients fully understand the goals that they're seeking with their care, that they want to participate in the goals that we have for them, and that they're shared goals. I heard all of the speakers today talk about shared decision-making and the importance of that dialogue. We need to acknowledge when we've had missteps in the treatment. Samira was telling me last night that for better or worse, she is an astute researcher and understood all of the different statistics around her care. And she told me that she would only take 8 a.m. appointments, right? So I only want when people are their sharpest in the day. And still, she had 2 different times where her chemotherapy was dosed inappropriately and caught that as a patient, right? So how do we build care with patients, making sure that when we do make mistakes, that we acknowledge that and apologize for that. We want to acknowledge feelings, and then empowering patients to be participative in their care, where they can voice concerns, ask us for what they need, help navigate them back to the right treatment pathways, and getting good advisors into their care. We have robust navigation services. We have other specialty disciplines, and I think a lot of our models are moving into a multidisciplinary model where you're looking at, patients being able to access all of the experts on the treatment team. And then I think it's important to note that many patients have experienced trauma of some type. It doesn't necessarily have to be a big T trauma, but even little T traumas can make it difficult for patients to trust in their medical providers and feel like they can be seen and heard. So we want to be consistent, we want to be calm, and we want to provide space for patients to be able to feel validated and be able to reflect on what they need from us. Some of the psychosocial interventions that we can offer include positive event scheduling, promoting support, distraction therapies, meaning-centered psychotherapy, dignity therapy. I do a lot of brief, meaning-centered and dignity-associated therapies, and then teaching patients how to continue to reappraise the events of what they're going through. Sometimes we can positively reappraise things, and sometimes it just is a situation that's not good, and you can't reappraise it in a positive way, so you have to hold space for the grief and feelings of disappointment that a patient would feel. And then at the very bottom, I have psychopharmacological interventions. Not every patient that we see in the psychiatric oncology department is going to need medications. And in fact, sometimes we're deprescribing medications rather than adding additional medications to the patient's regimen. We try to use briefer periods of time where we're using medications that can be at risk for dependence and different things such as the benzodiazepines, and if patients do need medications, something that has a safer medication side effect and tolerability profile. Cancer-related fatigue has been talked about a lot today, and we get a lot of different back and forth on are stimulants helpful for cancer-related fatigue. There was a study in 2024 that did look at the benefit of methylphenidate versus placebo, and ultimately methylphenidate did not outperform placebo and was found to be safe without significant adverse effects. So I think there are patients who can receive benefit from being on methylphenidate, but not necessarily a broad stroke application that we should be utilizing for all of the patients who come in. The truth of fatigue is it's really, really hard because we want to optimize sleep. We want to help patients improve their nutrition as much as possible. Dr. Hubert talked a lot about the intervention of olanzapine. That's a great medication where patients, if they're having a cluster of symptoms, we can utilize, and just helping patients to prioritize energy. It's important for us to make sure that patients presenting with medical psychiatric emergencies get referred into specialized psychiatric services. That could be patients with new brain metastasis, leptomeningeal disease. In our team, it's important for us to work up everything as medical first and then rule out all medical before presenting with any psychiatric intervention. Even delirium is a host of medical factors contributing to a person having alterations in mental status, and then how do we protect their mentation and continue to do both non-pharmacological and pharmacological things to improve upon their sleep. And then certainly patients who are at risk for suicide, we want to provide adequate support and get them to appropriate resources. Those are definitely the times we would refer to specialized psychiatric providers, as well as if patients are experiencing difficulty with mood symptoms for 2 weeks or longer, or it's interfering with their treatment, or you find that they're withdrawing and not participating in care. those would also be good times. If a patient's experiencing psychotic symptoms, certainly make sure that they're connected and being seen by a member of our team so that we can help identify if there's another medication they're taking or another illness factor that could be contributing. It's very rare for a patient to have a new onset severe psychotic symptom later in life, and so we want to work up where that's coming from and why. This is a quick pocket guide that is free and available through the American Psychosocial Oncology Society that has tips and tricks for supporting patients through psychosocial aspects of care that I just wanted to note and share that it's available with this QR code. And then I will end on this slide just sharing that what we do is really important, and we can't separate out the physical and emotional from the patient experience and what they're going through. So I had some other slides just about how we support one another, but I thought I would open it to questions and just see if there's anything that I can answer for you all before we wrap up today.